again, this was just a snapshot in time. And you know, everybody knew what we were doing in at this physician clinic and so on and so forth. So could there have been some prescriber bias because they knew that there were a couple of eyes in the skies like us watching over them? Yeah. But I think over time that kind of waned, and I think we were able to gather a good, you know, a good data gathering of what was going on. And I can follow up on that third bullet there a little bit here with my last couple of slides. The non-antimicrobial pharmacologic drug kits may increase due to our handing out of the viral cold kits. Well, sure, that was kind of a no-brainer there. So we concluded here that this was actually a successful intervention in what we were able to do. And you know, I think that our targets, our educational targets, that being physicians and mid-level prescribers, community pharmacists, and patients, was probably pretty good. Could that have been shifted a little bit more, maybe given the resources? Yeah, and we could have delved into that a little bit more to see how successful each one of those specific components actually was. But we did not do that in follow-up, but that certainly could have been a target for a follow-up study. I intuited, you guys, that these efforts should be on a continuum basis, or we would lose that momentum that we had gained. That was my conclusion. And for reasons that I could probably get into offline, we lost a little funding, or the funding shifted here a little bit for several different reasons. And the overall program tended to wane a little bit. However, serendipitously, a couple of years after this, there was a physician's assistant that was seeking his master's degree, and he used our data for his project, which was an infectious disease project and antimicrobial use. So he used our data, and basically, he got a master's degree on this, but he basically followed what we did in completing his project. So he did another retrospective chart review that was similar to ours, collected 333 primary care charts, and then examined the antibiotic use. What did he find? He found that the rates of the antibiotic use were significantly less compared to the previous study. That is, in this viral upper respiratory tract infection, 17% received an antibiotic review versus our 46. Remember, it started at 62. We dropped it to 46. In his review, it dropped to 17%. Now, was that due to our fantastic stewardship efforts? I don't know. I'd like to think so, but we don't know that because it was a 2-year gap. Nevertheless, you know, these efforts work in trying to curb inappropriate or non-judicious use of antimicrobials there. So I was surprised, pleasantly surprised to see that. So just real succinctly here, this was just an effort that is, if you're looking at kind of an outpatient type of antimicrobial stewardship project, this is just kind of an idea that there's a tons of different ideas you know, that we can do, but this was just one that I wanted to present to you guys. Be more than happy to kind of answer any questions on this one, or we can wait until Dr. Koo presents, and then trying to get out of here now. Okay, so sorry for my computer illiteracy there a little bit there. So we can wait for questions until Dr. Koo presents. If that's the way we want to do it, maybe that might be the best way. Dr. Koo?
All right, thank you. And actually, I'm going to kind of comment a little bit about your study. And partly is because, you know, a lot of our discussion on these webinars is going to be focused primarily on inpatient antibiotic stewardship programs. So many people are going to wonder, well, why are we bothering with outpatient, especially the fact that, you know, it's not being reporting of antibiotic use on the outpatient setting isn't really required, like, you know, in the same way as inpatient. And there are a lot of challenges, honestly, because you can't track use as readily as you would inpatient. However, I think that one of the big arguments for doing outpatient antibiotic stewardship is that if we can, is that a lot of what goes on in an outpatient setting actually directly affects inpatient. And you don't think about it from most of us, because we tend to kind of think, what goes on in a hospital is a bubble and nothing, there's not a whole lot of interaction between outside and, it's everything's contained within the hospital. But when you're having to deal with, a high prevalence or of ESBL producing organism, or even a CRE or MRSA, and all these organisms that can evolve and actually do evolve on an outpatient basis, it affects how we manage inpatient. Now, some of this is how much of an impact an outpatient program will depend on a lot of different factors, like the size of the community. The bigger the community, the harder it is to implement a lot of things. And so, for many of us here in Montana, it's a lot. It's not as much of a challenge to kind of get most of the clinician to kind of follow suit, especially if they're all employed by the same or part of the same healthcare system. So, but I think I just want to kind of bring this up because I know I don't see any faces. I see a lot, but I'm sure people are kind of scratching their head and kind of wondering, well, what's the point of outpatient antibiotic stewardship, and why should it matter to me? And especially if I don't have to report it. And there are some rationale for it. And as we progress, we kind of will touch on more and more about this. But thank you, Vince, for kind of bringing it up, because ultimately you kind of showed a short-term effect that you did decrease. Now, what we would really like to see is the long-term effect. And that's what, and how that will interact with inpatient, because it's not uncommon to see a fair number of patients who get, especially these little old ladies who get treated for recurrent UTIs and then come in with a ESBL producing bug and they've never stepped foot in a hospital. And you're wondering why, how did this happen? And actually that I get those referrals used to that when I was in private practice quite often, is because people just keep using antibiotics indiscriminately, or there's acute sinusitis, the viral URI, and they get treated with antibiotics very often. And then and it's actually interesting that it's not even just more an antibiotic stewardship part, but actually misdiagnosis. I actually diagnosed a person with a Wegener's because they thought she kept getting treated for 3 years for sinusitis, even had surgery for it and never got better. And they missed the diagnosis. So there's a lot of other things to kind of think about. But I'm going to move on a little bit, but so I can have time for all of you for asking questions. So today I want to just as kind of going on with our building your antibiotic stewardship program, at least just to go through the fundamentals, is I want to kind of talk about assembling your team, and this is something that I think for a lot of us, I'm going to surmise this, but for a lot of you out in the smaller communities, it is a bit of a challenge because for a antibiotic stewardship program to be successful, you really need to have the right personnel. And if you don't, then that program will continue to struggle. And I know that many of them, I'm just surmising that a lot of the hospitals where you work or facilities where you work, they kind of just designate someone who volunteers to do this. So, but again, I want to kind of go through this just really briefly, probably about 10 minutes, just to kind of identify some of the key personnel that you should have, at least to make that will make your program more successful. And if you can't find those people, there are consultants. Certainly here at Billings Clinic we do that for our affiliates. So there, but there are different ways to do this. But don't just want to go through just want to kind of point out some of the key personnels. So to kind of start with, is I kind of categorize into a core team members, and then those who are, if you can get them, be awesome. So so for the core personnel, you really want to have a pharmacist, or a physician, a pharmacist, and an infection preventionist all working together. Both the physician and the pharmacist would benefit if they're infectious disease trained. They do not have to be infectious disease physicians. This is a kind of something that people kind of get really kind of bogged down on, is, oh, we don't have an ID doc, so we can't run a program. And actually, that's not true. I mean, all internists and all our physicians should have some infectious disease training understanding. And, the more, obviously, the better. And I'll kind of go a little bit more detail why that's the case, why that would be helpful. It's the same thing with pharmacists. Having some understanding infectious disease training would help, but it's not necessary. Again, these are things that will kind of help try to make your program more successful. And then finally, many aspects of antibiotic stewardship have overlap with the goals of infection control programs. And so having an infection preventionist working with this team is really helpful. And again, I will kind of point out some of the key things why that be the case. But so these are the kind of, for all of you, kind of try, whether you have a team, a program, existing program, or you're trying to build a program, these are the three personnel that you want: a physician, a pharmacist, and an infection preventionist. And again, physician and pharmacist, if they're infectious disease trained, that would be very helpful, but it's not mandatory. So I want to kind of go down to a little bit of the roles of those three team members, because they play out, and just kind of go through what they kind of some of the things that they do and why it's important to have them on as part of the core group. The workhorse of the antibiotic stewardship program is the pharmacist. And JC Ott, who I just noticed on, is my ID pharmacist. She's absolutely fabulous. She does she runs probably about 80% of the program, and they do a lot. And so, and this is actually one of the reasons that if you're going to recruit a pharmacist to do your antibiotic stewardship program, they can't be trying to compete with other duties. That it's preferable that they have a substantial part of their FTE dedicated to do antibiotic stewardship, because they essentially run the program. So as I get a list, these are just here listed. These are just some of the roles that and the pharmacist, the pharmacy champion would do. They've compiled those lists of those patients who are in the hospital on antibiotic therapy. They look at culture results. They try to make sure that the bugs and drugs are matching, that they're on the right antibiotics for the right treatment, and that they're on the right doses. Very, very crucial, because wrong doses is a very common reason that treatment, cause of treatment failure. So that's part of what they do. And as with that, they interface with the medical providers. They either doing team rounds or calling them, contacting them directly to advise and try to, and a lot of times help nudge those providers into kind of follow the best practices. The other things that they do are they do projects, develop projects and try initiatives to try to support the stewardship programs. They coordinate some, they also work with the infection prevention program. So many, probably the best example is the C. diff facility, where we commonly think of C. diff as an issue for infection control, but antibiotic stewardship plays a very, very big part in trying to affect the C. difficile rate of a facility. So it's not just about making sure that disinfection and such, but obviously the appropriate uses of antibiotics and such. Other things is JC does this is when we compile the antibiogram, although that sometimes that is done by the laboratory folks, but depends. type of personnel you have available. They also will compile your regional or local antibiogram. And then finally, they also compile the antibiotic use data for reporting purposes. How much specific antibiotics are being used in a quarter, which antibiotics are most commonly used. These are all kind of graphs that they kind of put together. And this is kind of some of the things that the big C-suite is going to want to look at to kind of get an idea of how, one, how effective your program is, and two, is that what they could do to kind of help support you in new projects in terms of resources, funding, and such. As for the physician champion, their roles, the primary role of the physician is actually to support the pharmacist, and mostly in the clinical sense. If there are, and because again, it's kind of they will review a lot of these cases, especially the more difficult ones, to kind of see how they can align with some of the antibiotic stewardship initiatives. They, for a very difficult, and I'm sure many of you probably have this experience where, if you're trying to nudge a particular provider, it's probably like a surgeon. Yeah, it's hard. There is still, even though we try not to do this, but there is still a view of a difference in qualifications, a perception of that by certain providers. So when we're trying to get across certain initiatives, having a physician talk to another physician would be, you could probably be more successful in getting those changes. That it's all just more of a matter of a perception than such. Certainly, the physician champion plays a very big role in promoting an antibiotic stewardship program, because they're actually essentially, even though the pharmacists should get most of the credit, they don't get seen as much, and so they're usually, the physicians are the ones going to be, if there's any changes or any things that want to be any projects that want to get initiated, the physicians play a big role into trying to promote that. And then certainly they also play a role in developing antibiotic stewardship programs. And again, that kind of flows around with their relationship and in a relationship with other physicians. A lot of this is involving nudging, just kind of very similar to what Vince just kind of presented in his project. Physicians will kind of, you can use their clout or their influence to try to kind of get other physicians and other to be more compliant with some of the the things that you want to do with any projects that you want to start with. And then finally, the third core group is the infection preventionists. And it's, it kind of depends on who you talk about in that such, whether are they really important or not in that sense. I consider them important partly because many of their initiatives are aligned with that antibiotic goals of antibiotic stewardship really align with a lot of infection control goals. And so they kind of work hand in hand, and especially in terms of diagnostic stewardship. And because again, that plays, and probably for many of you kind of hear about this, why did so-and-so order a C. diff test when there's no, the patient doesn't have a diarrhea, but then the test turns positive, and you kind of, you get dinged, you get dinged for that case of C. diff. And that's kind of part of what I'm kind of getting is that there are going to be some overlaps, and so having these two teams work together really will benefit everyone. Probably the biggest thing is that most antibiotics, for most facilities, their antibiotic stewardship programs struggle with getting adequate resources. That's either whether some funding or just whatever, data collection, things like that. So having trying to incorporate and include antibiotic stewardship program as part of the infection control will certainly can make that can help with making some of the resource available. And at least this is a strategy you can employ. This is actually something that was just brought up in ID Week. One of the big conferences offered for ID physicians is that to try to include antibiotic stewardship program antibiotic stewardship programs with infection control programs. Here in Billings Clinic, we include our antibiotic stewardship program as part of our committee, the infection control committee. And so they report to that. And through that, we try to work on trying to secure fundings and resources so that we can, try to expand and initiate more projects. And then finally, is most infection control programs already have the ability to do data collections and analysis. So this is just making it a little easier on our pharmacists in in the data collection and data analyses. Other personnel, if you can consider, as part of the team, if you can. This is not so much as like the core, but it is going to be something that will make, make your program more successful. And they include getting an IT person. Certainly, it seems like that's an issue everywhere, including Billings Clinic. It's getting the adequate IT support. But they're the ones who are going to be working with you in data collection, setting up where they can do reports, as well as for those who have EMRs that can support this to do clinical decision support, like clinical pathways, or what we call order sets is the most common terms, or what we call here power plans, something that we can help guide clinicians into choosing the right antibiotics or choosing the right tests and such. So having an IT person is really helpful if you can get them to dedicate some portion of their FTE to both the antibiotic stewardship and infection control. Having a clinical microbiologist would be really ideal, but they are rare nowadays because not many people want to go into that. But they're very helpful in looking at organisms, especially drug susceptibilities and such, and there certainly can be helpful in a lot of the antibiogram, putting that together, as well as detecting cases of resistant organisms, or at least identifying trends. Then the last two, the data analyst, which is, again, as I mentioned, having someone who can kind of compile all the raw data into something that's digestible is really helpful. I mean, for a lot of places that kind of get dumped onto the infection preventionists and the pharmacists. But if you're fortunate enough to have someone who can help you with that, that'd be, certainly will help you be successful. And then finally, we tend to think about antibiotic stewardship primarily on providers, that for providers are the ones whom we're trying to influence, or at least directly influence. Having nurses as a part of your antibiotic stewardship program is also a very, very good strategy in trying to achieve that goal as well. And like, for example, for diagnostic stewardship, it's getting the nursing staff to kind of influence and decide, help get them to decide when to call their providers. So for a certain situation like diarrhea, or if, let's say, for example, we can instruct your nursing staff to notify if they are contacting their physician for, let's say, a patient with diarrhea, but and their physician orders a C. diff to test for C. diff. They can also ensure that, this patient's on a laxative or something to that effect, and will advise. So they can play a role in nudging the providers into making better decisions. So including nursing is also a very good part. So, and this is all I have. And I'm open for questions. I guess, and Vince and I will be open for any questions and such. We decided to kind of leave this a little bit because, again, I'm sure that this some of the of this will kind of generate some questions of how to fit your particular facility. But we're also open to any other questions about antibiotic stewardship if that's what if you have something like that.
Great, thank you, Dr. Hu. Great information there. So what kind of questions you guys have out there that we could offer some answers to or some opinions for? Anything out there? I have one for you, Dr. Kuhn. So in assembling your team there, how important do you think it is to include someone higher up? I mean, so you mentioned that you have the antimicrobial stewardship team that reports, belongs to and reports to the an internal structured committee within the hospital. Do you think you got to go beyond that? Do you have to have like an administrator, CFO, CEO, COO, somewhere along that line to provide administrative support, particularly when you're looking for resources?
That's a very good question, Vince. But what I present mostly is what CMS and CDC had recommended as part of the core personnel. But when you're running this, when you have a program up and running, you definitely got to find a way to make sure that it's well funded. And one of the challenges of antibiotic stewardship is that a lot of it is the fact that it doesn't really make money. I mean, there are ways you can kind of do it, but in the sense is that it is a challenge. So as you're kind of every year, when you're filling out budget requests and such, it's like, well, what's my, the question that most executives want to hear is what's our return of investment? How much, if I'm going to give you, $100,000 to do this, what am I going to get out of this? And that's a tough thing, and so to ask so yes, to having someone to partner up with the executives to kind of help with that, to see what the importance of antibiotic stewardship would be helpful. Now, there are something, if you can, that'd be great. I would say very few places will have executives actually part of the team, so to speak, because they're just like any other programs, that they have running throughout the hospital. So they, and then most places will just have it set up so that they report to the executives on the progress and what they do for the institution. But building a good relationship is very helpful. And then I think we're going to have a talk about that in a future webinar to kind of see what some of the strategies you can kind of employ to do this. So this is antibiotic stewardship is people commonly like to think of it like an island where it's just kind of its own little entity, kind of we're doing all, and but the truth is that it's really, to be successful, it has to integrate into the institution, just like infection control, like where we I hate to say it, but we have our hands everywhere, right? Because our influence, infection control's influence is almost everywhere, so prevalent. And that's kind of partly what we're trying to get with antibiotic stewardship, is so that it's part of everything, not just this little entity off in the corner of an office, and they're doing their own thing. Because once your executives start thinking you that way, it's hard to convince, because they don't, because they're just kind of think of it, always will struggle of trying to justify your worth, and that's, and it gets really tedious, and then it becomes very non-productive. So
excellent, great. So what else? I don't know, Jenna, did you check the chat box? Anybody throw a question out there? Or
there's nothing in chat, but feel free to chat if you have a question.
Okay.
We don't bite.
Yeah.
Oh, I don't bite. I don't bite.
Neither do I.
Maybe let me ask this for the audiences. We are, again, we put together this webinar series based on some templates of other webinars that we're familiar with, and we really want to make this work for our region, for Montana and parts of Wyoming and such. Certainly, feedback really would helpful. I mean, if you don't find this helpful, let us know. I see a fair number of people online, and I know that they want something, I'm sure all of you are here are involved with it, your antibiotic stewardship, but one way or another, one fashion or another. So what format and what is this little lectures helpful? Or what other things we can do to help you to have a successful program? And I got one question. All right, should I just gotta read this? For small facility, one pharmacist, do you have any recommendations on how much time a pharmacist should spend on the antimicrobial stewardship program? And that's from Charlotte. That is a good, good question, and it's a little challenging because if you ask JC, I think we'd have conversation where she, for, let's say, I'm just doing something a reference, but like for Billings Clinic here, when we clone her, if we can clone her to do multiple tasks, would be great. It also kind of comes down to what you're trying to do with the program. Yes, you have what the CMS has required, the minimum to meet their condition of participation. So, I would surmise, a minimum, and JC, you may want to chime in at this just based on your experiences. I would surmise minimum of 50% of FTE, if not more than that. Again, this is as I kind of listen out what the pharmacists do as part of the antibiotic stewardship program. They are the workhorse of the program. So so depending on how much responsibility is being added, even 0.5 maybe even too low. I would say 0.75, but I would say that ideally that if we're to have an antibiotic stewardship program, regardless of the size, that having someone who's dedicated almost entirely at FT of 1 would be ideal, and because you can always find more projects for them to work on. So. Second question is, do some of your clinic providers also work at the hospital setting? Do you think the clinic study would carry over to the hospital ED as well? I think this is to Vince.
Yeah, so not so much anymore with that hospitalist model that's taken over. So that's made it a little bit more difficult in just from the respect of not that they're mutually exclusive, but you have a gap there, and that transformational gap, communication gap, or at least a delay in that communication gap. So that makes it a little bit more, I guess there's two ways to look at it. It makes it a little bit more difficult to optimize the communication, but also makes it more important to get that communication across, because once that gap is missed, I mean, either coming, like Dr. Koo was referring to, if you have someone that's been treated on the outside and failure, and then all of a sudden they get admitted with this gorilla bacter, and you're thinking like, where did that come from? Then that kind of underscores or emphasizes the importance of communicating from the outside to the inside. And certainly when you have someone that's discharged and is going into that outpatient setting, while that usually there's an infectious disease component there that connects that, following up with that, I think is tremendously important. So so that as a background, I think that some of those projects or processes, especially with critical access hospitals, because of the close proximity between the inpatient and the outpatient, is I think those are critical in terms of would that study and the components of that study carry over well? Absolutely. And I think I would argue that you'd have a better opportunity to close some of those communication gaps, because you don't have that widespread array of hospitalists and specialists and so on and so forth. There's you have a lot of the people wearing a lot of different hats, or the same person wearing a lot of different hats, and some of the communication can't get lost. And I think that's an advantage. While it piles on more work for sure, I also think it's a little bit of an advantage. So in short, you know, would that study like that I presented there, would that carry over to a hospital? I think yes. I would argue yes. I think there's still room to fit something in there like that. And so I don't know if Jenner or Neil or JC has any other opinion on that, but I think it still has a place for, you know, in that setting.
Yeah, I agree, Vince. I think you're exactly right. I think this is one area where some of the smaller critical access hospitals actually have an advantage over the larger hospitals because there is so much overlap in coverage and so much better communication, close proximity. A lot of the critical access hospitals have outpatient clinics either close by or within the same facility as the hospital. So I think in that case, it does make it a little bit easier than it does with some of the larger facilities.
No, I agree. And you know, and what the project that Vince presented may or may not work for you. I mean, you know, a lot of these projects has to be kind of tailored to, you know, the settings and the community. So and one of the things I want to kind of bring up here is that I don't want to give you all of you who are attending this the impression that there's a cookie cutter way of doing things, because it's really, you know, one of the at least nice things about antibiotic stewardship doing any of the projects is that you could go different, you can address different issues and go different directions. I don't think that as far as I know, CMS or you know, even like the Joint Commission, DMV, all these going to nitpick about exactly what projects or what you have initiated. Although there is a few things, like I think you know, ensuring that there's an indication or something like that. But you know, but as long as you're actually actively working toward a goal, and that may be the hardest is for many programs starting up, is to see the bigger pictures and coming up with a goal to kind of and then start developing little projects to kind of reach that goal. And you know, so don't feel like you have to reach goals like by, you know, in 6 months, and nobody does actually, not many people. But the idea is to kind of put something together so that what you're doing will eventually reach that goal. And you have to tailor it. And this is actually what we're hoping with this webinar, to have everybody have an input, is that people can throw different ideas in there, and then you just put together what will work for your facility. That's really the goal. It's you know, because I'm not going to present anything of the projects that a major academic center like the University of I know Colorado will be doing, because it won't apply to you. It won't work. It's too, you know, because they have a different setting, they have different populations. So that's really one of the intent for this for the webinar is for us. This is for us to pitch ideas for each other to see what worked for someone, so that others can kind of help follow suit. Let's see. I got another question about advice for smaller facilities, such as for smaller facilities such as critical access hospitals that do not have the resources of larger facilities. Well, well, obviously, I don't want to say you make do with what you have. It may not be the best answer for you. Now, one advantage is at least is that because of this, the condition of participation, you know, your executives are probably, it's a little bit a lot harder for your executives to say not to not offer you resources, because of the fact that, you know, if they're going to get reimbursed by CMS, they need to at least to help you to do something that will be considered as an antibiotic stewardship program. It won't what you get may or may not be as grand or anything to what Vince has presented. But I think the point is that you're putting something together that will eventually reach the goal. So you may end up you know, so a lot of it will have to be sitting down with your executives, get your physician champion to do that. That's what, you know, some of what I do. Go and talk to the executives about, okay, look, you know, if we got, you know, we have to do this. This is not an option. So, and have that person talk to the executive to make the program work. And that's, again, that's why I say that physicians are important. Having a physician champion is important because that's one of their roles. Let's see. Well, and I'm for this is for Raquel. I hope it does is helpful. I know human resources is a huge that's an issue everywhere, even here at Billings Clinic. And it's even worse now because of all this change in behaviors of people.
Right.
So I'm not sure how to solve that. I think a lot of people have that. If we have an answer, if any one of you have an answer to that, please let me know, because I don't know. We're struggling for our personnel too. So
yeah. And I think we've kind of touched on things before, and it's really key, the synergism between the physician champion and the pharmacist and administration, which is kind of why I brought that up, in setting priorities. I mean, if you can rearrange where this sits on a priority level, because it has to sit up there relatively high, and pick a project, not something that's overwhelming, but something that is going to be, fruitful for everyone involved, including the hospital and so on and so forth. And that's something that I think from that perspective, you can put a joint effort into achieving and bringing to fruition.
And just so that, as I pointed out earlier, if you're for any antibiotic stewardship programs, you don't have to do it alone. That's actually why I mentioned about joining forces with infection control. If you now granted, if your infection control program struggle, that's maybe then we may have to work on that. But most executives recognize the need for an infection control program, so you can use that advantage. Join forces, combine all the resources, and then talk to them about getting and then kind of talk about how these two will be important and how they complement each other, and then the need to kind of have to support these two programs. So those are kind of some of the things that you may want, at least some strategies you may want to employ just to see to get more resources. And then let's see, there's another question. If you're seeing improvement in a project, how long do you suggest keeping that project before moving on? So that's a good question. And so because I think this is kind of, I'm assuming that's kind of in line with what Vince has had as project, but this is for any projects. For most of our projects in the hospital setting, is that the hope is that we can instill permanent changes in behavior. That's, and that's 99% of what I do, and JC does, is that, even though we collect data, we look at all this stuff, ultimately, and is that the goal is to change some behavior so that the practitioners will stop doing what they were doing before. All right, whether it's inappropriate ordering antibiotics, or put everybody on Bosin who comes in with community-acquired pneumonia. I had a hospitalist that used to do that all the time. So so part of the project, as you're designing projects, is that you want to kind of see if you can make that into a more of a permanent thing. Now, having like projects like that Vince did, where he put these little kits, that may be a little challenging because you don't want to do that. I don't know if he wants to do that forever, but the idea is that you're hoping that you can substitute that with something else that may be helpful. Having those little viral respiratory kits for patients to go home with, because I think one of the biggest problem why some, at least on an outpatient setting, why some physicians are more inclined to send patients with viral URI home with antibiotics is that for one, is that that's what the expectations of the patients. Patients are coming to them to get something, and usually they're kind of assume the antibiotics is going to cure them. They don't want to go home with nothing in hand, and that's part of it. So putting together, having a little respiratory, treatment, symptom kit will give that percentage, and you can substitute, and that's something you can probably easily done, put together little kits where it doesn't include antibiotics, and so that patients will perceive as, okay, at least I went home. Now, granted, again, this is kind of nudging them, but ultimately in the end, there's for all of you kind of keep in mind, what drives a good portion of what drives physician is the fear of doing something wrong, and their scores that they get from their patients. So those are, so you kind of want to keep those things in mind as you're putting together any behavior change projects. So.
Yeah, the only thing I would add to that's a great answer. The only thing I would add to it is go into something with some sort of an objective, so that you can, once you have approached that, you can have some sort of a measure of your success, or that reveal something that didn't work. So once you meet your objective, or once you're along that way, then you can scale back or stop, and then just temporarily or periodically go back and check that once you've changed the behavior. And that's, I would underscore what Dr. Koo said on once you've changed that behavior, and you're essentially sure that that's, we got everybody on that track, then you can just periodically kind of check that. But it's an ongoing type of a thing for sure, because we're trying to change the paradigm. So good. We're at the end of our hour here, and I really want to thank you guys for being attentive, and the questions that were offered there. Those are good, and again, we want to make sure that everyone has this is a role in this, and can play a part, because it's engaging. We're just trying to lead the discussion here, and so once again, I want to thank Dr. Koo for his expertise. And presenting and sharing his knowledge and so on and so forth. Thanks to you all out there. And I'm trying to be respectful of everybody's time. So I guess we'll see you again in a month. In the meantime, if you have questions, send them our way. We'll get the recording out. The recording will be there, and we'll send the slides out, or have the slides available too. Is that correct, Jenner?
Yes, so all of the recordings and slides will be available on the Mountain Pacific Quality Health website.
All right. Great. Thanks, you guys.